Welcome to this Clinical Explainer. Look, today we're stepping right into the shoes of a critical care consultant. We're going to build a hyper-dense choice architecture so you can rapidly navigate some seriously complex pulmonology scenarios. Let's get to it.
Here's our roadmap. We've got PFT and DLCO forks, the PE Wells criteria, ARDS diagnostics, and finally, we'll wrap up with some absolute clinical traps to avoid. All right, Module 1, PFT dissection and DLCO forks. So why does the FEV1 to FVC ratio force our primary divergence? Well, we're looking for this ratio to drop below 70% to confidently lock in an obstructive profile. If it's obstructive, the air just can't get out, which pushes up your total lung capacity. Now, restrictive profiles, they're going to maintain or even elevate that FEV1 to FVC ratio, but you'll see a massive drop in total lung capacity. It's a strict binary split.
Once we've nailed down if it's an obstructive or restrictive defect, we use the DLCO, that's the diffusing capacity for carbon monoxide, to completely isolate the exact pathology. An obstructive pattern with a low DLCO, that points directly to alveolar wall destruction, emphysema for sure. But if it's obstructive and the DLCO is totally normal, you're looking at asthma or chronic bronchitis. On the restrictive side, a low DLCO isolates interstitial lung disease or idiopathic pulmonary fibrosis. Meanwhile, a normal DLCO points to an extrinsic or neuromuscular cause. Think obesity, ALS, or myasthenia gravis. When you isolate that low DLCO obstructive pattern, this is exactly what you're looking for on the films. Check out those hyperinflated lung fields and flattened diaphragms. This is physical, visual confirmation of emphysema. Okay, let's test this. Picture a 54-year-old dyspneic patient featuring an FEV1 to FVC ratio of 58%. Obstructive, right? But they have a completely normal DLCO. Our choice architecture literally forces a diagnosis of chronic bronchitis here, safely eliminating emphysema or those idiopathic pulmonary fibrosis decoys. Moving on to Module 2, pulmonary embolism and the Wells criteria. Let's navigate the hemodynamic execution boundary. For stable patients, if the Wells score is 4 or less, you just get a highly sensitive D-dimer. Negative, you safely rule out a PE. If the score is over 4, you completely bypass that D-dimer and order a CT pulmonary embolectomy. But wait, what if your high-probability patient develops hemodynamic instability, say a systolic blood pressure dropping under 90? They absolutely cannot safely travel to the CT scanner. You have to pivot immediately to a bedside echocardiogram, looking for right ventricular strain. If it's there, you're executing systemic thrombolysis or a surgical embolectomy right then and there in the resuscitation bay. Your clinical intuition heavily weights this Wells score. Just asking yourself, is PE the most likely diagnosis, actually buys you 3 points. And notice how quickly a post-op or immobilized patient with a resting heart rate over 100 crosses right into the high probability tier. They accumulate points so fast, pushing them way past that crucial score of 4. Now here's a massive clinical trap. A normal chest x-ray in a highly symptomatic bedridden patient, it absolutely does not rule out pathology. In fact, it pretty much confirms your suspicion of a ventilation-perfusion mismatch driven by a PE. Module 3, ARDS Diagnostics and Vent Mechanics. You've got to verify the Berlin criteria, specifically isolating a PaO2 to FiO2 ratio of 300 or less. But once you validate ARDS, you have to execute the ARDS net mechanical ventilator mandates. We rely heavily on lung protective ventilation to prevent volume trauma. You've got to set tidal volumes strictly to 6 milliliters per kilogram of ideal body weight, never ever actual body weight. From there, you titrate PEEP and FiO2 to maintain oxygenation while strictly keeping that absolute plateau pressure capped below 30 centimeters of water. Remember, timing is literally everything. Rapid bilateral infiltrates popping up immediately post-trauma, that isolates a contusion. But consider a 75-kilogram septic shock patient developing diffuse edema over several days. That's true ARDS. And if refractory hypoxemia persists despite optimized PEEP, it's going to force you to rely on early prone positioning, up to 16 hours a day, to recruit those collapsed dorsal alveoli. Finally, Module 4, Clinical Traps. Let's utilize the AA gradient for clinical reconciliation of hypoxemia. Think of the alveolar arterial gradient like a giant barrier. If your hypoxemic patient has a normal gradient, oxygen is actually crossing the barrier just fine, but not enough is getting down to the alveoli in the first place, so you execute a hypoventilation protocol. But if the gradient is elevated, oxygen is seriously struggling to cross that barrier. You're dealing with a VQ mismatch right there, like a pulmonary embolism. So to wrap this up, you have to avoid these disruptive critical care traps. Never, ever order a D-dimer in a patient with a high pretest well score. It just delays getting them to the CT scanner. And chew on this final scenario. An intubated trauma patient suddenly drops their saturations, showing high peak airway pressures, but completely normal plateau pressures. How do you sequence mucus plug suctioning versus PEEP tuning using raw pressure matrices? I'm going to leave you to analyze that choice architecture. Think about it.